Wow, okay. Good afternoon, everybody. I have the honor of introducing Dr. Chesnut here. He initially hails from this very state and went undergraduate and to medical school and did his internship all here at the University of Washington, and then maybe wanted some sunshine, I'm not sure. Went to UCSD for his neurosurgery residency and spine fellowship, and then seems like you slowly made your way up the coast, never strayed from the West Coast. To UCSF, OHSU. I may have skipped something, but finally came home, yay, in 2004. And Randy talks, writes, and publishes extensively in the areas of critical care and trauma, and that's exactly what we're going to hear about today, new things in spine trauma. So thanks very much.
Perfect. Actually, I went to San Diego to play rugby because they have a good rugby team. So I could do both. Okay, what I was asked to talk about really is spinal cord emergencies, and I'm kind of going to focus on where we overlap a bit or what we think we know. No conflicts here. Goals of today's presentation are two. One is to present clinically useful information. I'm not going to wander into n-dimensional vector space on theoretical mechanisms of injury. And the other thing, I'm not going to present information readily available elsewhere, because modern days you can Google it and get it in 13 seconds. So I'm not just going to parrot the literature. I'm going to try to focus on places where the literature is unclear and other places where the literature may actually be misleading. So I may hopefully get some use out of this. Now, one of the mantras of all neurology, and no matter if it's surgical or non-surgical, is avoidance of hypoperfusion of the injured nervous system. And some of us, maybe some of us, no, probably not, remember several decades ago when we actually restricted resuscitation fluids on trauma. So if you had a head injury, you got TKO'd, whereas if you didn't have a head injury, you got full resuscitation fluids. It was really thinking that high blood pressure was bad for brain trauma, and that was a terrible decision, but it was probably the hallmark of induced hypotension and making outcomes worse. In terms of spinal cord injury, it's also felt, perfuse it or lose it. Laboratory evidence of strong role of blood pressure in recovery from injury, where you make a model and then hypoperfuse it and it worsens the injury quite clearly. Human clinical evidence is hard to find. It's really hard to study in an independent fashion the effects of shock on outcome. And actually the best paper was from Charlie Tatter a long time ago, which was from a large prospectively collected spinal cord injury database. And they pretty strongly correlated with increased mortality and decreased recovery, and also the idea that hypotension can convert an incomplete lesion into a complete lesion. So underperfusion is our enemy, as it is in most neurologic disease. Now, if you connect the spinal cord to the head, and you believe that there's some relevance there, if you study the head, the effect of perfusion is really amazing in trauma. This was the paper that turned around the under-resuscitation of trauma patients and resulted in full resuscitation of trauma patients. Now, and what we did is we looked at a very, very simple one measurement of a systolic blood pressure of 90 or less during the pre-hospital period through resuscitation. So it's a minimum, a form first injury, and we found it was associated with a doubling of mortality. So it was a pretty dramatic effect. And this is actually now the most quoted paper in neurotrauma, and it had the result of changing our resuscitation to a much more realistic fashion. We looked a little further at this. We wondered, well, if early hypotension was bad, how about hypotension that occurs right under our noses and in the ICU? And again, the old definition was associated with a strong tendency towards vegetative outcome or non-survival. But late hypotension in the ICU is also associated with the same. And when you started to look at statistical independence, they were independent predictors of outcome. So, you figure once you get to ICU, you're safe. Well, not true. These are still sick patients with varying blood pressures and varying perfusion parameters. And so we really need to be careful with perfusing the injured spinal cord. And personally, I hate it when I look at a patient who's got a mass lesion or a trauma, and you walk in the door and they've set blood pressure maximums, and you've got nicardipine hanging to try to control the blood pressure. That, I would much rather have hypertension than hypotension. So the number one drug, and this is probably the most disappointing slide I've ever put up, is that despite the billions of dollars of research we've done, the number one drug is our resuscitation fluid. You can replace this with whole blood or plasma or whatever, But whatever it is, it's still pretty basic fluid. Perfuse it or lose it, if anything, is the take-home message. So how about perfusion of the injured spinal cord? Because it's something we see all the time in spinal cord injury. And animal models suggest that the concept is that after trauma, autoregulation of spinal cord blood flow is compromised, and so the injured spinal cord can't sort of titrate the perfusion pressure to maintain perfusion. It can't dilate or constrict based on alterations. It's flow passive. And that as you develop ischemia and edema, this becomes more acute. Post-traumatic hypotension, reduction of spinal cord blood perfusion, and a worse neurologic outcome. But when you start looking at spinal cord perfusion and measuring it in the laboratory, it's unclear if spinal cord blood flow can be reliably increased after SCI with vasopressors alone. It's not consistently found. What is more consistently found is if you add an ancillary agent that starts to mess with the vessel, like calcium channel blockade. If you add calcium channel blockade and then you vary the blood flow, you get much more of a pressure passive response than you do with just raising the blood pressure. We like to think we're doing something because the bedside monitor looks better, but whether or not we're helping the patient is unclear. So there's reasonable evidence that systemic hypertension is associated with impaired outcome, and there's clinical evidence, but again, class 3, that elevating the blood pressure is associated with improved outcome. There is that correlative, but there's been no controlled trials. And so what does the question become? The question becomes, are we actually benefiting the patient by improving perfusion with elevated pressure, or are we simply avoiding hypotension? If you set a target, a mean arterial pressure target of 60, and your definition of systemic hypotension is a systolic of 90, you're going to vary around that, particularly in a somewhat unstable post-traumatic patient. If you set your perfusion pressure of 90, and you have the same variation, or even worse, you're probably going to have your definition of hypotension much less frequently met. So are we just avoiding hypotension by setting a higher target, or actually benefiting the patient with the increase in pressure? And the reason is because raising pressures and giving pressors to patients who are trauma patients is not good for them. Pressors are poison, particularly in patients with altered flow and maybe relative hypovolemia, third spacing. You end up with splanchnic hypoperfusion, ATN. It's just not good for it. And hypovolemia is also a problem in these patients where it's hard to figure out what the central volume is. We also are very uncertain about how high, how long, and how to taper our blood pressure parameters. So when you start to look at the literature and you start to figure out, and make tables of the various studies, you find out there are no systematic studies of magnitude, duration, or agent. So we end up making this stuff up. Well, neurosurgeons have never had a problem with making stuff up. And they did. And they came up with the guidelines, which are currently in revision, but I'm not sure they're going to look much different. And they give us some targets. And now the current target recommended is to target a mean arterial pressure of 85 to 90 for 7 days by volume expansion vasopressors in spinal cord injury patients. Now, if you think about it, that's 7 days in ICU, flooded, hopefully flooded, and on pressors. That's simply not good for you. And a lot of these patients, if you manage them correctly, can get out of ITU at 4 days. So there's an extra 3 days there. So this is not a benign treatment. It seems like a great idea, but it'd be nice if we knew we were actually helping people. At Harborview, we actually don't go that way. We have somewhat different, based on our interpretation of the literature, we've come up with a different paradigm. We target mean of 80 for 48 to 72 hours in patients who don't have surgical decompression, who are injured and it's a status quo. After surgery, we do it for 24 hours after surgery. Again, and we taper it off over 24 hours, and we closely observe them for a neurologic change over that period. So we get the idea that should we go to 7 days? Well, it'll depend. If we see any wisp of a neurologic change with our taper, we'll protract the treatment. And interestingly, we just don't see that. But the issue is we avoid hypotension. The second parameter is that it's a mortal sin to have hypotension. So the nurses are running around with infinite sphincter tone about maintaining the blood pressure. And that's, I think, what the money is. And it's the same in cerebral perfusion pressure in the head. I think most of that is about avoiding hypotension and not about augmenting blood flow by getting carried away with our numbers. Now, we're not just going to accept that. We are actually studying it. The Temple study is a randomized open-label trial, 152 patients with a traumatic spinal cord injury, closed injury, T8 or above, an Asian score of A, B, or C, greater than 18 years, who are randomized to two different blood pressures, one elevated and one status quo. Again, because we decided to study the blood pressure level, we maintained the recommended duration, and our outcome is an Asian score at 6 months. So we're going to try to come up with at least whether or not we need to augment the level. If it turns out we do, then we can look at the duration. But hopefully we can sort this, because the current status by recommendation, which are way overinterpreted based on the level of evidence, is somewhat toxic. Now let's talk about pharmacologic improvement of outcome, and in trauma and that particular spinal cord injury, it's about steroids. In 2002, neurosurgery published guidelines suggesting that high-dose methylprednisolone of spinal cord injury is recommended as an option. Now that's class 3 evidence, they called it, and recommended as an option. Now in the absence of much further data, actually, but in a lot of sort of stylish change in posture, in 2013, it was published as not recommended as a class 1 recommendation. Now, how they got from class 3 to class 1 and from do to don't without any further data is astounding. And people read these, and they don't pay attention to standards or options. The average reader just kind of reads the abstract, and this is what is recommended. So it's a real problem. So it's probably worthwhile go back and look at the studies. So the study that sort of set off this bit was the second National Acute Spinal Cord Injury Study. And it was a randomized control trial, looked at methylprednisolone versus naloxone versus placebo, treated for 24 hours. They studied sensory motor recovery, and they looked at spinal cord sensation and motor change. Now, the study was designed at a 14-hour cutoff. So within 14 hours, you got treated. And that's the initial design. And analyzed in terms of the 14-hour criteria, there was no significant effect. So the study was a wash there. But given that they couldn't keep their hands off the data, post hoc analysis looked at if you were treated within 8 hours compared to naloxone and placebo, high-dose methylprednisolone resulted in significant sensory motor improvement in both incomplete and complete injuries without significant comorbidity. And so that's kind of what got stressed in the publications, and really the primary outcome at 14 hours got completely lost. And patients treated greater than 8 hours didn't do as well. Now, this is obviously not class 1 study. This is publication of a randomized control trial, which carries all of the gravity of that, which published it actually as class 2 at best data, but was misinterpreted in terms of its rigor. The major weakness of the studies, gosh, it wasn't significant as the study was designed. So all the stratification, all of the study design applied to the 14-hour group. There was no functional scale, and then some patients had only mild sensory deficits. So it wasn't perfect, even analyzed post hoc. And interesting, if you look back at the study, the best treatment was placebo at greater than 8 hours. So maybe that's what we should be doing, but that's not what we're doing.
What was the intended purpose of the naloxone? What was the theory behind that?
Because the funding agencies were being co-funded by a drug company who wanted to sell Narcan. That's honest. I was just a resident in that study. I didn't help design it. But
there was some strange data.
There was some strange data, but it wasn't nearly as strong as the methylprednisolone study. So there was a little collusion in there. I was being a little facetious, but it didn't really belong there, and it would have been easier to have more patients in 2 groups than 3 patients, etc. And the blinding was terrible because the pain treatment in patients on Narcan gave immediately, everybody was unblinded. So anyway, what happened was the LA Times somehow got hold of this data before it was published in the New England Journal, and people were calling us from all over that patients had read that you needed these drugs for spinal cord injury. And it became standard of practice in the 90s that everybody got the 24-hour drug based on this, 24 hours of methylprednisolone. And so we asked about 5-6 years after that study, we're at a meeting, large number of spine surgeons. We gave a vignette of a patient with a spinal cord injury, high spinal cord injury, complete quadriplegia, who had been bolused in the field with methylprednisolone. We asked them what they would do. And the vast majority would continue it for the 24 hours. And then we gave them a bit of a Gedanken experiment. We said there were no lawyers in the US and there would be no lawyers for the next 20 years. And the changes were different than most people that wouldn't have used it. So people had kind of thought this through to some extent. And this is really unfortunate when your treatment's being based on parent litigation. It got a little worse because then there was a study, the third methylnascus trial, which then stratified patients based on time after injury. Less than 3 hours got the previously studied 24-hour total treatment. But for patients who came in between 3 and 8 hours, they got 48 hours of treatment. They were randomized to 48 hours. This paper was published as compliers in the analysis, which kind of couples up the class 1 study of the RCT. And if you analyze compliers only, they got an effect. And that's what was published, that was what was interpreted, that's what you read if you read the paper sort of cursorily. If you looked at the intent to treat analysis, there was no significant effect, which should be what we were reading. And this is kind of what happened, is there was a transient effect of this which washed at 1 year. And so why is it important that it washed at 1 year, that it wasn't durable? Well, because primum non nocere. Severe pneumonia was statistically significant increased in the longer duration treatment. Sepsis was not significant, but sepsis is sepsis, not particularly good for you, and was more frequent in the 48-hour treatment group. And there was increased mortality in the 48-hour treatment. Again, not statistically significant, but when you're giving a drug that may or may not have a real effect and you're hurting people with it, it doesn't seem like a good idea. And even though the interpretation of that paper was interpreted as supportive and the general reader was now starting to think in terms of 3 to 8 hours, 48 hours, it was pretty dodgy data. So somehow you have to come up with rational use of this. And so what should the recommendations be? Well, what's the level of evidence? It's probably class 2 at best, but it's still supportive of considering it. Does it work? Maybe a bit. Does it have a profound effect? Probably not. Is it harmful? Not probably when used for 24 hours, but much more likely when used for 48 hours. Based on this sort of analysis, what do we do? Because we've got to make a decision. We've got a spinal cord injury patient in front of us. Well, rational evidence, and I think that the most rational thing to present to people who are in the field and want an answer, they don't want to read the literature, they want you to tell them what to do, is to consider using methylprednisolone for 24 hours, not 48, in adult patients, because that's what the study studied. PEDS patients don't tolerate this drug as well, and there is no RCT on kids. With closed spinal cord injury, because we didn't study open injury, and we didn't study cauda equina or conus injuries, and no contraindications. So if you come in with an open wound, which is going to get infected, or aspiration, which is going to get infected, or diabetes, and there's a reason not to give steroids, you shouldn't. And that usually means younger patients. The general feeling is in that group, you should consider steroids. You don't have to give them, but it's not verboten either. If you look at the current literature, there's still this debate is really quite hot. There's still people who've made their career yelling about anti-methylprednisolone. And there's another group that now is for it, but used to be against it, and has gone both ways. If you look at the Cochrane Library recommendations, methylprednisolone works, but it was written by the first author of the original study. If you look at the more recent systematic review, it has reasonable possibility of working, but it's still kind of maybe. And interestingly, if you poll patients and you try to be realistic to them about this may or may not work, etc., do you want it or not, they overwhelmingly want it. So in terms of the environment in which we live, this is kind of where we're at. I think reasonably it's a treatment option. You, as a physician, in the face of an individual patient, can use it or not use it. It shouldn't be forbidden and it shouldn't be mandated. I think that's the most logical improvement. But if you talk to people, if you support the possible use of this, you will have oranges and apples thrown at you from the audience in most meetings. But yet, if you go through it this way, I think it's the most reasonable way to approach it. Now, there's a lot more agents on the market. There's a lot more agents in research, and it applies to a lot of diseases other than spinal cord injury. But as of right now, there is nothing out there that is ready for human clinical use. And I don't know if you see them with your diseases, but certainly I see patients both with head injury and spinal cord injury come in anticipating or having just spent $50,000 to $100,000 out of pocket for some treatment, stem cell injection, etc., somewhere around the world, who would much be better off if they banked that and saved it for an orthotic at some time or another physiotherapy visit, etc. And they come in and say, is there something more I can do? And I want to be realistic and I want to be optimistic, but I have to be honest with them. And right now I tell them no. that there's a better use. You should approach your disability with the idea you can do anything you want with proper motivation and help from rehabilitation medicine, but you should not simply wait for a cure. So how about timing of surgery? Another big one. What do you do when someone comes in with a neurologic deficit and they've got compression? Well, there's experimental evidence supporting early surgery, although it's not uniformly the case. It tends very strongly to be effective less than 3 hours, but up to 8 hours is where it starts to get dodgy. So there's this very short window where you can put pressure on a cord and then remove it and get recovery. So that's the idea behind early clinical use of decompression. But the lab is not real life, right? We have a controlled impact versus random trauma, isolated spinal cord injury versus polytrauma, controlled systematic variables versus uncontrolled and often quite variable systematic variables like blood pressure and oxygenation. The decompression is simply to remove the weight in the laboratory. The decompression in human clinical situation usually involves surgery, which involves setting up, getting there, doing the decompression. It's in a lab, controlled lab versus a chaotic ED and scene. And it's in healthy subject versus patients with comorbidities and other injuries. So it's a huge step from laboratory to real life. And yet we want to make that step. And then if you decide to do a bar whisker exam, this is most amazing, of what has been studied. This is a bar whisker representation of the hours since injury that have been studied in human clinical trials. And this little bar here represents the optimistic window of the laboratory timing of effective treatment. So you can see that even when you want to do research, you can't really do it within that time. So this is a huge problem because the laboratory research has led to people being optimistic, but can we pull that off? Can we decompress the cord within 3 to 4 hours of injury and therefore perhaps be able to generalize from the laboratory to the human clinical situation? And we have to do it, remember, without hypoxia or hypotension, because that secondary insult is going to undo what we're trying to do. And it's possible, actually, with good protocols, that if you have a jump for sets and you can pull the head back into alignment, that you can do it in a short interval. And at Harvard, we've got these protocols set up where very quickly we can realign the jump facets. And that is the decompression. It doesn't involve surgery at all. It just involves sort of orthopedic routine sometimes. But in terms of surgical decompression, it doesn't happen. I mean, realistically, even if you're quick, it's just not going to happen within the limit of the laboratory, certainly not within 3 hours. And that was what was reflected in an evidence report published at the turn of the millennium, and people were pretty realistic about it, although everybody still wanted to support early surgery. And then the Staskis paper was published, which is now the klaxon, the bell telling everybody they have to rush these patients off the theater. And this was an interesting study. It was done, and then it went completely radio silent for a couple of years, and then it was published, which always makes me suspicious. But anyway, that was what happened to it. It was a prospective observational study comparing outcomes of 182 cervical SCIs chosen for surgery within 24 hours versus 181 whose surgery occurred greater than 24 hours from injury. Now this, by definition, is a convenience cohort. So there's no control of why they were chosen for early surgery. And then, after adjusting for significant covariates, including the pre-op neurostatus and steroid administration. Now, isn't that interesting? And if you look up here, the first author, I don't know how to use this, the first author was the guy who had been pro, anti, now sort of pro in that previous study I was in. And in order to find, I believe, a statistically significant finding out of these data, he had to force into his stratification equation whether or not they got steroids. Because if he didn't, there was no effect of the timing. And that changed his position. So there's this funny inbred loop there. But anyway, the published was that multivariate analysis showed that the odds of improvement of greater than or equal to 2 grades were much higher if you had early surgery. And that's what's causing everybody to want to rush these people off the theater. Not that simple, though. There was no control over early choice. So there was no matter how you analyze it, you can't control for why a person might have been chosen by a surgeon to be operated on immediately versus later. And then the primary outcome, if you read the materials and methods, the primary outcome was ordinal change in AIS grade at 6 months, which means greater than or equal to 1 level. If you look at that, it wasn't effective as described. But if you can't keep your hands off the data, you will find something that was positive. And analysis of greater than or equal to 2 grades was significant. However, if you think about it, this was a spinal cord injury study. So patients who are Asia E, which have no deficit, aren't going to be included. So the best patient, actually, the least injured patient, was an Asia D, and that's minimal injury, right? A slight motor deficit, but still quite functional. But an Asia D patient can't increase 2 levels because you can only go to E. So how you can justify this analysis under these conditions is curious. And if you then go to the paper and sort the Asia D patients, you lose the significance that they reported. And then they also fooled around with facet dislocations, which shouldn't even have been in this study because that's a totally different injury. So we end up with a study that is being heralded at centers that don't always have the capabilities of major trauma centers as forcing people to take people to theater at 3 o'clock in the morning for spinal cord compression. It did suggest that maybe there's an effect, but it did not strongly support it. It pretty much did show that at large trauma centers with specialty, you can do it. The worry has always been that you'll make someone worse. And you can't, at Harborview, we can do it at any time, pretty much. But Harborview is Harborview, and most spinal cord injury patients are not taken care of at places like Harborview. And so as academics, even though we think we live in the real world, we don't. And it'd be nice if we could give something to people who actually do the work. And we're very poor at that at academics in all our fields. And this is a problem because this is what the average person in the audience at a spinal cord injury lecture hears, and they think they need to go off to theater. And at most places, you end up with an anesthetist who's asleep and a circulating nurse that doesn't know a pedicle screw from a pessary. And the real problem is that's the condition under which you're taking a very sick patient and trying to operate on them. And again, I can't stress enough that one episode of hypotension while the anesthetist is waking up is going to undo everything you think you can get. So except in exceptional circumstances, we can't achieve decompression within the limits that the laboratory shows that it works. There is evidence that it may be safe in select centers, but it cannot be mandated. So again, I think the take-home lesson for anybody who's not practicing at a major trauma center with all these resources is to redefine early surgery as urgent surgery, to suggest that urgent is defined as the earliest time when conditions for optimal surgical management can be arranged. If you can do it at 3 o'clock in the morning with the A-team, all power to you. And that usually means the patient's not systemically ill, doesn't have a ruptured spleen or liver that could bleed on the table. It's probably more likely in the cervical spine than the thoracolumbar spine. But again, based on the evidence, you need to develop protocol. The safest thing at most centers in the world is to line them up for first start the next morning with the first start anesthetist, the first start scrub team, spine team, proper imaging. And that, I think, lowers the likelihood of secondary insults and increases the likelihood of good outcome. That's a realistic impression of what I think this study implies. But again, we don't have strong evidence, and the impression is that we do. Now, I mean, again, trauma is unique. There's a lot of aspects of trauma that make it not generalizable to other forms of spinal cord compression. And I think this is probably the best example. And the problem is, oh, I don't know if this is going to run. This is quite unfortunate. This is what happens when you load it onto another computer. Okay, well, this is an example of an MG Mini flipping over and over at a rally, and every vector of force was exerted. So then you see the final result of this guy being way off in this field. And mechanism of injury was what? Usually we think, was this a distraction injury, flexion compression, rotation? Probably this spine saw every mechanism. And then when did the neurologic injury occur? And when was maximal compression? Because what we see is this. We see this on a backboard in the MR after transportation or resuscitation. And we try to say, is this patient going to get better and how badly they're injured? In a patient who may be in spinal shock, so you may not have a proper exam. And then those are the ones we randomize to studies. So just realistically, trauma, where the most data is very complex situation, and I think we need to be quite cautious in what we generalize from this. There is evidential support for emergent decompression in other lesions. And I think we can talk about neoplastic compression and epidural abscess, which are a bit different. And there's dodgy data really actually for cauda equina, although it's quite litigious. In terms of neoplastic depression, I think the clinically relevant conditions are that revolve around a couple major issues. And one is expeditious diagnosis. And if you look back from the stories you get from the patients you see in the emergency department, the first thing is you always wish that the primary care physician had been more attentive. And that is when a patient comes in who has known cancer and says, my back hurts, the general thought seems to be, well, I need to get an MR. I don't have an MR here. It's a pain. I'll sort of think about it once you come back in 2 weeks. That seems to be the logic. They have an X-ray machine in their clinic, but it's not sexy to get an X-ray. But if you get an X-ray and you see what we call a winking owl, that's a dead giveaway. Now, if you see a complete vertebral collapse, that's pretty obvious. But if you see, well, I can't remember the computer, but I mean, here's a winking owl. The eyes of the owl are the pedicles, and the spinous process is the beak. And here's a winking owl because the right eye's gone. That's really easy. That's really straightforward. The radiologist will call you if you can't see it. And that patient doesn't go home from clinic. He gets imaged and sorted. And that's what we need our primary care docs. The other thing is as we know, as neurology people, all of our medicine colleagues are more than happy to take on any disease known to man that doesn't involve a neuro exam. But when it involves a neuro exam, they're never happy with their exam, and they call us immediately, and they don't do the exam or they don't believe their exam. And so what we end up with is patients who come in with early deficits, and there's no action done on them. They may even be documented as suspicious. I think that's the other thing we need to pass on to our colleagues so that we don't see these patients late. Because the other thing we need to do is maybe talk to any known cancer patient about what to do if you think you have it. It's like stroke, same kind of deal. It's not you go back to sleep or you think it'll go away tomorrow. You know, we get patients all the time. You ask them, when's the last time you could walk? And they tell you it was 5 days ago. And if they come in having been completely plegic for 24 to 48 hours, they're not going to get helped by heroic surgery. So again, expeditious diagnosis is the crux here. It's like prevention in trauma. We should put ourselves out of business for this disease. And then one major collision, at least in the current spinal surgery environment, is the collision between what needs doing to decompress the cord and what can or should be done mechanically. And so if you see a lesion like this, here we have a nice lesion, involves two vertebral bodies, looks like cancer, sort of spares the disc, is compressing the cauda equina, and the alignment isn't too bad, the height isn't lost. I mean, I'd like to have a CT to show that the bone isn't too rotten, but you might actually be able to sneak in there, decompress them without fusing them, okay? That's nice. That'll give the patient relief, not require a big whack, etc. Now here's a patient, and here you can see at the thoracolumbar junction, there's quite a bit of compression right up here, but there's also cancer at other levels. And if you want to sneak in and do a laminar decompression at the thoracolumbar junction, they'll simply fall off. You take away the tension band and they arc forward. Even if you decompress them, they will then bowstring over that knuckle as they kyphose, and you won't do them any favors. And they'll end up with a profound deformity. If you decide to instrument them to allow you to do a decompression, where do you end up? Because when you instrument someone, you make a long lever arm. You change the moment. And so if you stop here, this level will collapse. If you go to L4, 5 will collapse, and the sacrum has disease in it. So if you start down that road, where do you end? So you got to figure out if you should even start, and that's the money. The best thing to do would be to call up your oncologist and have them give you a prognosis. That would be the best. But as you know, they never want to do that. They're always hedging, and especially at 3 o'clock in the morning, they don't want to do that. So we've come up with sort of some simplistic ways of attempting to estimate, should we load this patient up with a big surgery in the face of their disease, which we may not fully understand. And it's all really based on level of survival, length of predicted survival. Indirectly on functional, but really on survival. And unfortunately, no scoring systems, and these have been iterated several times. Some of them are pretty good, but none of them has more than 90% consistency. The most common one is the revised Takahashi score. And this is what we tend to use when we see a cancer patient, particularly with known disease, because this is one for known disease, who comes in with spinal cord compression. And again, it's based on how long this patient's going to survive. And we use a number of issues: general condition of the patient, the number of extraspinal lesions, the number of metastases in the vertebral body, number of major organs involved, primary cancer type, and the status of the nervous system. We add these up, and based on the sum, we tend to make these decisions. And if it's 0 to 8, we think in terms of conservative treatment, and this is where we really end up not doing anything. 9 to 11, we think of palliative surgery to improve the patient's quality of life without a long-term solution. And this may involve a construct that won't last 5 years. Methyl methacrylate, something quick and easy, but will never result in solid biologic fusion. And then if it's longer than that, you start to think of something that with much more longevity, and that actually will give them a cure or a good outcome for a longer time. And really the goal is not to have the patient spend the best months of the rest of their life recovering from surgery, because that really does happen. And even though technically we can do something, sometimes it's a really bad idea. So making these hard decisions is about when the necessary surgery is bigger than the patient can tolerate. Some patients just don't have the physiology to tolerate a big surgery. When the likelihood of early construct failure is even higher with the proper construct, and that's what we saw in the image I just went over, that if we do a long instrumented construct, it'll result in a disaster, so we don't have a place to stop. And then when the tumor type is aggressive enough that regrow will undergo decompression no matter how aggressive we are. And that will happen also where you'll get a transient effect, and then 3-4 weeks later they come back with a nice looking construct, but the tumors grow back. And they're still getting over their first surgery. The hardest decision in medicine across the board is when not to do something you can do. And that's what we're talking about. But realistically, when you're dealing with patients with limited prognosis, sometimes it's actually better to spend the next 3 months of your life actively with your family in a wheelchair than it is on your back trying to get over the complications of a major heroic surgery. And that's what we're trying to talk about here. So there are, of course, other lesions and other considerations. It's always nice to know the tissue type. That's what we always want to know. When we don't, it's a real problem. And certainly with issues such as lymphoma or multiple myeloma, simple radiotherapy can result in rapid decompression. And actually with multiple myeloma, you can actually heal biomechanically scary lesions after radiation. So you don't need to construct those. So knowing the tissue type can really help. So about epidural abscesses, these are a strange disease, and this applies to both intact and compromised patients. There's the effect of direct compression. They come with epidural abscess, an intracanal mass lesion decompressing or compressing the cord. But there's also a very strange phenomenon of cord infarction, apparently inflammatory, of uncertain etiology, but that doesn't recover. A lot of times if you just have a knot compressing your cord, we can decompress you and you'll do better. If you have this go on, then it doesn't get better. And you can see it on MR because it's much more extensive than it should be from a simple compression. But and that's why, at least at Harborview, if you have an epidural abscess, intact or not, at the cord level, we tend to approach it. We decompress it and see if we can find some purulence to drain. At the caudal level, it depends if you have deficit. We treat it much more like a herniated disc because that vascular phenomenon doesn't appear to occur at that level. Surgical concerns, obviously if you can get posture happy, you can't always get it. You can't really tell a phlegmon from a pus pocket despite what the radiologist will tell you based on contrasted MR. And it's not easy to look under these constrained circumstances. But if you can find purulence and drain it, that's really what we're after. And if it's phlegmon, you then have to ask yourself, do they need the much bigger surgery to take out a solid mass lesion, which is often anterior? Simple disguidance versus compromised biomechanics. Is it just drainage of pus or is there major reconstruction? And then organism. Unfortunately, a lot of these patients come having been diagnosed at some remote hospital, treated with every antibiotic known to man, and then sent to us without blood cultures. And so then we don't know what to treat. And then Cauda-Equina syndrome, sort of to finish, perceived as a medical emergency. There is not great evidence to suggesting what is usually felt, and that is that the degree of recovery relates to the urgency of decompression. There are some anecdotal reports from the UK, the NHS, which is pretty slow about things, where the timing of decompression didn't really pan out as a predictive variable in the degree of recovery. But it's never been systematically studied. But I can tell you that it will be studied by the lawyers, and if you don't do these straight away, you can find someone to defend you, but it's not worth it. So you got to treat these as an emergency. And the causes, I think we all know. Most of the time it's disc herniation, second most common is stenosis. I have no idea why you get acute Cauda-Equina syndrome because you don't get acute stenosis. But be that as it may, that's what you see, and then there's other causes. Now, what you usually get, at least at Harborview, is we have a 35-stone patient with some symptoms that they want to transfer you for, and they don't have an MR that will fit them. And you know, we don't either. At Harborview, we don't. I think you might have one here that's a little bigger than we have. And so the question is does the patient actually have caudate equina syndrome? And the exams are not often well done. And does the patient have a lesion consistent with the diagnosis? And that's a funny question, I guess, except an interesting paper published out of Edinburgh a number of years ago, where they looked at 66 patients with a diagnosis of caudate equina over 10 months. And they found those that ended up actually having normal imaging had a high frequency of symptoms and signs that were quite predictive of this disease. So they had the diagnosis, they just didn't have a surgical problem. And this is the issue with transfers in to a surgical center for operative management of what may not actually be a lesion. They called them likely to be functional. And that's something you can say a lot easier in the UK than you can in the US. Because you can certainly see patients who it's just pain-related. They hurt, they're inactive, they can't make it to the loo in time, so they have incontinence. Or they get anticholinergic effects of their opioid narcotics or something like methocarbamol, and so they get retention. So there's all sorts of reasons other than purely functional. But we do see this group of patients, and they're kind of hard to manage. And you will run into these patients, on both ends. You'll want to make the diagnosis, but it may not be surgical. So it's not that straightforward, unfortunately. And that's pretty much where I've gone with spinal cord injury. I think I have some time for questions.
Can you describe in a little more detail the process of reducing a jumped facet joint? Do you do this under the imaging, or how do you pick this up and make the move to do this?
Well, it's controversial, and a lot of people will be aghast that you do it mechanically. The classic way to do it is to put people in traction, get x-rays every couple hours, and increase the traction. But the mechanism of jump facets is flexion and distraction. So my chest stops, my head doesn't, and it gets pulled off transiently, and when it relocates, the facets instead of in the back are in the front. So if you reproduce the injury mechanism, you can get them unloaded and then guide them back. If you do that slowly with repeat imaging, it's hard to do, unless they're really loose. What you can do mechanically, what we do at Harborview, is we take them down to the PACU. This is all protocolized now. And anesthesia is there to give them a bit of analgesia and relaxation, but to give the exam, because you don't want to paralyze them. And make them relaxed. And then we, under fluoroscopic guidance, we can actually manually reduce them. And you can reproduce the injury. It's pretty scary, actually. But you can flex them and distract them, and then get the facets to come up to where you can pull them back. And then you pull them and lay them back, and that's instant decompression, no incision. If you can do that, and patients sometimes will just say, ah. Sometimes you'll actually hear the click, and then somebody will pass out. But patients will actually, you'll see them get relief right in front of your eyes. That's a beautiful case, because that's an instant decompression. If you do it the old way, and it's a much more English way than American way, but if you do it that way, it seems to have a very low complication rate. It's not done that commonly, but that's the way we do it.
What would you say the fraction of that kind of mechanism for all cervical spinal cord injuries? You know, is it 50 or less?
Jump facets are something like 15%.
Oh, so it's a minority.
Yeah, it's a minority. And the rest of them, you can put them in traction, but a lot of times that's just delaying until you can get surgery up and at them.
Okay, thank you.
Yeah.
Do you use Gardner Wells tongs, or what do you grab on?
Yeah, you use tongs, and you actually have to use the steel tongs. The MR-compatible titanium tongs won't take an orthopedic Brutane pull, and you will pull them out of the head, and that leaves big red marks, and then you have to put the steel ones on. So it's kind of a funny deal. And it's something that needs to be protocolized, because if it's not, and you're making it up as you go along, it won't work very well. But we have it, you know, nuts and bolts, A, B, C at Harborview, and we have really pretty good results with it. And it's really useful also in patients who are too sick to go to surgery, who may have a ruptured spleen, and general surgery says you can pull on their head, but you can't operate on them.
Well, this explains why you don't have a movie of that procedure.
Gosh, I'd love to have a movie, because we have great, I do have sort of stills that are sequential. Yeah, but it's something you're concentrating on, because it's quite bizarre.
Well, we'd like to have a movie of a patient going,
I've seen that, and I've also literally felt a clunk as it slipped back, and then I have to sort of check my underwear. I mean, it's really, oh my God, are they still intact? But I mean, I think the reason that's important is because that is a case where you can expeditiously decompress someone if you have the protocol. Taking them to surgery is just a slow process.
So there's a ton of literature that comes out all over the place about the post-spinal cord injury period where you're hoping that the patient might be able to either regain function in some stretched axons or remyelinate, or actually, if they haven't killed off all the cell bodies of those motor neurons, get some axons to penetrate the scar area.
Yeah.
Is there anything out there that strikes you as ready for prime time, or is this still in limbo as a strategy?
Well, let's see. What's that?
I mean, I'm talking about olfactory epithelial cells, Schwann cells, stuff to get rid of the lamina, all these things. So
Now, the problem is all of those things you just said seem to play a role. Do you have the axons to do this? The glial scarring can prevent the passage. So there's a lot of research on tubules and reimplantation simply of scaffolding to do that. Then you have to support the crossing, and then you have to remyelinate them. In more simple animals, there's some exciting stuff. In the primates, there's really nothing that's really exciting. As you know, rats are pretty hard to knock off permanently. So is there anything that's coming to the fore? I think not for axontometic injury. For it may well be that some of the no-go inhibitors are close, and some of the sodium channel sort of stabilizing agents can maybe improve function on partially injured neurons. And there are early studies started on the latter. But as far as something that you can tell patients to sort of keep track of, nothing yet. It's complex injury, and there are a lot of different factors. We tend to focus on one little bit of it in a model, and nothing that is translatable to clinical reality yet. I mean, maybe I'm being a bit pessimistic, but these are patients who are searching for anything, and if you give them a slight bit of hope, they'll put all their eggs in that basket.
What kind of sodium channel stabilizing agents are being studied?
Sorry?
What kind of sodium channel?
I'm trying. Gosh, it's just. Sorry, I worked last night, so I'm still a little bit sleepy. It'll come to me in a second. It's one you guys use actually for myasthenia gravis, not myasthenia, multiple sclerosis.
Okay. Fampridine.
Sorry?
Fampridine.
Yeah. Yes. Exactly. Yes. I can't forget what the song is.
That was great. I was struck by some of the commonalities with your comments about hypotension and what we deal with stroke. And I wonder, have you banned propofol from your unit, or I just feel like this is a constant battle.
Yeah, and ICP can be treated with propofol, but what happens is you treat the patient with propofol and then your CPP goes down. If you have autoregulation, you recruit blood flow, so your head fills up with blood and your ICP goes up. Your ICP goes up, so you treat it with propofol and you make the problem worse. And you can also do that with barbiturates. You can also do that with dexmedetomidine. So I haven't banned it because we don't have a lot of great other agents. But again, we know what the concepts are, and it's so important not to make the patients hypotensive. Maybe ketamine is a better sedative to use because that's not going to have that effect. There are some people working actually with scavenging systems and using volatile anesthetics in ICU to try to avoid that. It's a bit of a sticky wicket, but I think what we do, we use propofol for sedation, and then we try to keep the nurses from overusing it. Don't go to high dose. Try another agent. Figure out if the patient has autoregulation and base your treatment on their sort of autoregulation. Now, we can't measure autoregulation currently in the spinal cord, not clinically, not even experimentally very well in the human. So that's a bit of a sticky one, but you're right. And it happens, I mean, I see a lot of times when we sort of co-manage patients with intracranial hemorrhage where we let them have an EVD, and we walk in and there is a light shielded bag being infused in the patient because somebody wrote a blood pressure max. And it isn't too hard to add a little propofol and then a little bit of antihypertensive and end up with a hypotensive patient. And that doesn't do anybody a favor. So I think there's a huge bit with stroke.
Yeah, they figure with ischemic.
Yeah, and the worst thing you can do to the injured nervous system is to give it a secondary insult, no doubt. Okay, well,